Good morning, everybody, and welcome to the West Suffolk Clinical Commissioning Group July board meeting. Do we have any apologies, Jo?
Apologies have been received from Jane Palin, Andrew Hassan and Byron.
Thank you. First of all, we are to take the annual report and accounts. You will have had the opportunity to study this. If Jane is not here, does anybody wish to say anything about it? Ed, do you want to make a comment other than to thank warmly the people who've been involved in its production, because it's quite a mammoth piece of work to get everything together, and we are very grateful that it's just presented to us all ready and polished and everything, and so we must pass our thanks to them. Do you have any comments on it, Ed?
Yeah, no, I would agree with that. Thank you for everyone, not only for putting the report together, but for all the work during the year, which has been excellent. Mark Game is on the call with us, and he'll talk us through the accounts and the financial aspects of the report. But just to highlight in the report the strength of primary care, which our patients really benefit from in West Suffolk, and I think is a great foundation stone for us. I think in the past year we've made great advances in terms of our mental health strategy, and we're seeing the benefits of that approach to integrated care play through currently during the COVID crisis. I think we've seen the development of integrated neighbourhood teams in our communities really move forward, which has been wonderful. And the report highlights the comparatively excellent cancer survival rates that we've got in West Suffolk, which we're very proud of. At the same time, we have seen some significant challenges in the past year at the West Suffolk Foundation Trust with a downgraded CQC rating, and I think that's a big challenge for us to support going forward. But overall, I think some very, very positive achievements during the past year, and of course our financial commitments were met, including those relating to the mental health standard. So I see Jeff's got a comment, but I'll hand over to Mark to talk through the accounts.
Jeff, does your comment come before the accounts, or does it refer to the accounts in the audit letter? I think you might be on mute.
You hear me now?
Yes.
I was just saying the account. I was just going to say thank you to the finance team and all colleagues for keeping the budget on track. Obviously, we hit our target, which was excellent. Also, all the governance and audit arrangements around the accounts were exemplary. The internal audit report was very good, the audit opinion. So I'd just like to thank the finance team and all the management for an excellent set of accounts and performance through the year. I think the future is going to be much tougher, but we're in a good place to address those issues. So again, thanks to everybody. So thank you.
Thank you. Shall we move on to Mark, please, for
yes, thank you, Chair.
Annual audit letter and the accounts.
Right. Can I just draw people's attention to the link that's in the agenda? So that's where the annual report is on the website. So obviously members of the public can view it there. Just want to briefly just say a few points around the annual report before I go through the presentation. The 1920 report is more concise than previous years, and that's down to the impact of COVID-19. There were reduced national requirements for 1920, so if any members of the public or members of the governing body are comparing reports sort of year on year, they'll see that there's a complete section that's been removed, which is around the performance analysis. So it's been removed. It wasn't required nationally, and because of all the pressures under the CCG were under due to COVID, we just followed the national guidance and produced a slimmed down report. Now moving on to the actual presentation. As you can see, we achieved our financial targets for the year. The table demonstrates that. And I just need to draw your attention to the fact there is a typo on the first bullet point, which says 394.44 million. It should say 397.44 million. So the CCG achieved its financial target surplus of 1.2 million, and this is demonstrated in the two lines within the table, which state the total income of 398.7 against a gross spend of 397.5, and also the allocation, which was our 385 million against 383.8 million. So those are the areas that demonstrate our 1.2 million surplus, and that's where they're recorded within the accounts. Also within that table is our performance against our running costs, so our cost of actually running the CCG, and that also shows that we've delivered within budget, and we've delivered under budget by 500,000. So that's a 500,000 underspend on our running costs, which means that the money was obviously diverted towards patient care rather than running the organisation, which is again, really good positive message. Now, we submit the annual reports and the accounts on time within the national timeframe, thanks to our audit colleagues, and we received a very positive unqualified audit report, which we'll discuss in a little while. It's worth saying that we have other targets. These are around the payments of invoices, and it's particularly worth pointing out that we paid over 96% of our non-NHS invoices within 30 days, and the target's 95%. So it's important that we keep paying our non-NHS suppliers as well as our NHS suppliers within sensible timeframes to support them. And likewise, all our internal audit reports, they were all showed either reasonable or substantial assurance. So throughout the year, all our audits have been very, very good and very, very positive. So moving forward to where we spent the money. So we had 397 million, which was spent in year. 94% of that was spent in 4 key areas. The main one being the purchase of healthcare from NHS organisations, that being NHS trusts and NHS Foundation trusts, and that's demonstrated by the large blue section on the chart in the presentation. The next area is the purchase of healthcare from non-NHS organisations, and that's followed by payments for primary care services, which includes the GP contracts, and obviously payments in respect to primary care networks this year as well, and prescribing being the other area. So 94% of our total spend is in key areas of healthcare. It's worth saying that our spend on prescribing has increased by 4%, but that's less than our total expenditure increase of 8%. So we're doing a good job of managing our prescribing budgets. There's a lot of pressures around cost, but we're doing very well with managing that. And likewise, our spend around primary care has increased by 10%. But again, a lot of that's around our investment in primary care compared to the acute service, and also our investment in primary care networks. Just moving on very briefly to the final slide, which is the statement of financial position, or the balance sheet. Now, the balance sheet's a strange beast for CCGs, because if you were to look at this as a normal business person, you'd think that it's an organisation that you would in no way invest in because of its high level of liabilities. That's very normal for a CCG. We don't hold much in the way of assets, be it physical fixed assets or even sort of debtors or cash. Our cash comes direct from Treasury, and so we're expected to hold very low cash balances. And our liabilities are what we owe to other NHS bodies, other individuals, but also, and a large majority of that liabilities figure relates to our prescribing, which is 2 months lag in prescribing payments. So if it's all right, Chair, I'll move straight on to the annual audit letter as well. So the annual audit letter is produced by our auditors, Ernst & Young, and obviously is a reflection of what's occurred in the audit. So if I briefly just go through the executive summary to start with. So Again, COVID-19 had an impact on the audit, so the audit process was prolonged this year. So rather than everything being drawn to a conclusion on the 28th of May, it went through to the 25th of June this year, which gave the auditors actually a longer audit period. Didn't actually give us as a finance team any longer to produce the accounts for audit, but gave the auditors longer to audit it. And obviously that deadline of the 25th of June for filing these the auditor's accounts was met. Now, the auditors were slightly concerned this year about something called going concern. And the going concern is whether the CCG will be in existence for the next sort of 12 months after the date that the accounts are signed. Now, I think there's recognition that obviously we will be in existence, but there was some doubt around the fact that we're moved into these emergency funding arrangements because of COVID for the first 4 months of the year. So that resulted in an additional amount of work from the auditors looking at that area, and it also required us to put additional disclosure in our accounts. So if governing body members and members of the public are interested in that disclosure, it is on page 107 of the annual report and accounts in the actual document itself. And it just explains a bit more about the emergency period that we've been under for the last 4 months and the block payment arrangements and the general sort of unpredictability of the environment that we're currently working under. So moving forward through the executive summary, it then just passes comment on the various different statements, etc. So our financial statements are unqualified, which is good. Our regularity of income and expenditure likewise unqualified, and the other important one is the value for money conclusion, which is the auditor's conclusion around whether we've got best value from our expenditure, and they've got no matters to report in that as well. So all very, very good. If I just now move on to key issues. So the auditors, again, didn't manage to pick up very much at all, which is very good. So there was one key issue that the auditors picked up on, and that was around a provision which we have in our accounts for 0.4 of a million. And this is the same provision that was in our accounts in the previous year, and a similar disagreement with our auditors. Our auditors don't feel it is a provision. We as finance professionals believe it is. It relates to the risk of a non-NHS contract failure. We feel we've got justification for having it in the accounts, and as per 1918-19 accounts, we included this in the accounts for 1920 and didn't adjust. If you look at the materiality figure that's included in the report as well, the CCG's materiality limit is 7.9 million. 7.9 million is the threshold at which the auditors become very concerned that our accounts don't truly reflect what they would expect, and would ask us to start to amend. So the fact that they've only actually discovered errors of 0.4 of a million, and when working within those thresholds, just shows that it was a very good set of accounts, and the auditors were very, very satisfied. Likewise, their reporting threshold is 300,000, so hence the reporting of the 0.4 million provision difference. The only other thing I would just bring people's attention to, and this is more for the governing body rather than members of the public, but it's just around audit fees, and it's just to be aware that although we have a base audit fee of 55,000 for the year, West Suffolk CCG was selected by the National Audit Office as a sample site, which meant that our auditors had to do some additional work for the National Audit Office. So that resulted in an additional fee of £1,800. And likewise, all the additional work that related to COVID-19 has resulted in an additional fee of just over £6,000. Now, that's a lot of that work is around the going concern issue that I mentioned earlier. At the moment, we are discussing that with our auditors, as we feel that is quite a large additional fee, and we're not particularly happy about it. But it's something that we'll take forward as a finance team, and we'll feedback results around that. And that's all I've got to say around the annual report, accounts, and the annual audit letter. So if there are any questions.
Does anybody have any questions? Okay, well, it seems very straightforward then. And so we're very grateful, as I say, to accept those and the work, the considerable work that's behind them. And thank you very much.
Thank you.
We will move on then to the general business. Apologies have already been reported. Are there any declarations of interest? Okay. May I draw your attention then to the minutes of the last CCG governing body, which you will now rush to look at. Does anybody have any comments on those minutes, particularly challenges for accuracy? Okay, so I propose that those minutes are accepted as a correct record of the last meeting. Thank you very much. And we need now to look at any matters arising. And the action log.
Should I take us through that, Christopher?
I think that will be great. Thank you, Kate.
Apologies, because I had in my head that we started at quarter past 9, so I was still chatting to the cleaners in West Suffolk House at 9:10. So apologies for being slightly late. I think we've covered off most of the actions on the action log, unless any of the owners have anything to add. So for community services, there was an inquiry around the leg ulcer healing rates, and that's currently being audited by the team, and they're evaluating whether or not that gets rolled out any further, or whether to continue with that as a pathway. Lisa, do you want to add anything to that, or is that still a work in progress?
I think it is still a work in progress. I do need to, so that, as you know, there's been a lot of communication about this. I will just change that update slightly, because subsequent updates, I don't think the work has been rolled out across the whole of West Suffolk. I think they are currently, as you say, auditing practice across West Suffolk to then understand what the baseline is and then potentially roll out was the most recent update that I had. So I'll just change that, but there's certainly work ongoing with it.
And on that note, I've asked to see some of the figures around the healing rates. I think just to however they substantiate the option they decide to pursue. The next one around freedom of information, that's on the agenda that Amanda's going to present a paper, and there was also an inquiry around the A&E reporting, and the hospital are still not reporting on that. They're still reporting on the KPIs associated with the national pilot. Richard, I don't know if you want to add anything to that.
Only that the HSJ was reporting that we may actually get a national announcement pre-winter around whether or not they roll out the standards that West Suffolk are piloting. So it's another way to see, really.
Brilliant. And that's it for the action log, Christopher.
Thank you very much. Ed, a general update, if you would, please.
Thank you, Chair. So firstly, a warm welcome to Paul Jabara, who's joined as our new Director of Performance Improvement. Welcome on board, Paul.
Thank you.
Governing body meeting. Well, I'm sure we'll hear more from you later. I want to start with the state. So the Oakfield practice in Newmarket has now relocated to Newmarket Community Hospital. It's a fantastic premises have now got, and staff and the patients are delighted with it, which is great. So well done to all the CCG staff involved in facilitating that move. So thank you very much. Secondly, plans around the new hospital for West Suffolk are starting to mobilise, and there's a project group that's starting to form. So I'm sure that we'll have regular updates to this governing body as that work starts to progress. Thirdly, and just for information, really, the Ipswich and East CCG governing body and North East Essex CCG governing body met as a committee in common to approve the development of an elective orthopaedic centre at Colchester Hospital to provide a centre of excellence for inpatient surgery, and that's part of our system. So an important development there. The fourth area I was going to touch upon was recovery. So there's a lot of work underway around the recovery of our NHS services, and I'm sure that will feature on the agenda. The government have announced 3 billion funding to support the recovery, which will cover the independent sector, testing, and the Nightingale hospitals. And we're awaiting a letter from the Chief Executive of NHS England probably next week to set out the requirements and expectations for the ongoing recovery. This is a very challenging area for us because some of the capital plans that we'd set aside may well be unfunded. So we're developing collaboration between West Suffolk Foundation Trust and ESNEFT to see what we can do more collaboratively to recover our services, and that's a big focus of our work now and ongoing. Suffolk County Council with partners have published an outbreak plan, so all local authorities are required to have outbreak plans. And the background to this is that the management of COVID outbreaks is being pushed more locally, which we welcome, so that decisions around how we manage an outbreak, if we had one, for example, in West Suffolk, would be agreed locally. Next thing I want to just mention is that Age UK Suffolk, the operation has got into financial difficulty and will be closing as a company, although the services I'm sure will continue under a different guise. But it's just a reminder of the pressures that our voluntary sector is under, and we need to be very alive to. The next point I was going to make is that the government are launching a big push around a national obesity strategy, and I think that would be good for us to take stock of the work we're doing locally in Suffolk and to perhaps prepare a paper for a future governing body on how we're responding to that agenda. And then finally, there's a lot of work underway in Suffolk around supporting our Black, Asian, minority ethnic communities, which have been disproportionately impacted upon during COVID. So we're working with our communities to support them to make sure that we're better prepared if we have a second peak of demand. And those were the updates I was going to give, Chair. Thank you.
Thank you very much. Does anybody have any questions on that, please? Okay, thank you very much indeed. On then to the section of strategy and service development. We don't have a patient story this morning, so we're going straight on to item 7, which Kate will lead us on the update for the West Suffolk Alliance. Thank you, Kate.
Thank you. I'm not going to go through all of the paper because quite a lot of it you've heard some of before when we've had our regular updates. We've tried to keep you informed of most of the bits and pieces that the teams have been doing during the last 3 months. But what we tried to do in this paper is bring it together, and as it's a public document, just have a bit more of an informative walkthrough how services have changed and how we've used staff differently to support the public. So if I walk you through some of the headlines. So when we began to at the beginning of March to look at how we provided services differently in light of the pandemic, we established a tactical cell for our alliance partners, meeting on a weekly basis. It was twice weekly initially, and then later moved to weekly, but bringing together all of the system partners to talk about how we shared resources and wrapped around our population. And from that, I think most of you have had experience of, we were able to move very quickly and put in place changes that perhaps in a different time would have taken us a lot more time to achieve. So I think that it's be good as a board to publicly note the cooperation and the support that we got from all of our system partners as part of that conversation. The paper's broken down into examples really of how we acted differently and the impact that that had. So section 3, we've got some examples of how we were able to make some rapid decisions around changing some of the services. Our Suffolk GP Federation was really instrumental in terms of being able to mobilise different services that could be accessed by multiple professionals that were delivering care to act as either a resource to carry out face-to-face visits and interventions with the patients, but also as a centre of advice and guidance to stop some of our professional colleagues having to go through some of the normal channels and have, which often prove challenging, and have direct conversations with clinicians around what needed to happen to provide the right level of care. Good examples of that being direct access for community hospitals. Care homes was probably one of our biggest changes in terms of developing that relationship, and our community nursing teams and ambulance services being able to directly dial in and speak to a doctor in the first instance to get advice on how they dealt with certain situations. We also set up several forums which were about operationally managing services differently on a daily basis. So we set up, from a primary care point of view, a daily conversation with all of our practice managers, who obviously were instrumental in terms of changing the way that we were able to deliver primary care, moving services, a large chunk of services, onto virtual interactions and sharing resources where needed, and having plans in place to ramp up where necessary to make sure we provided the safest services for the professionals delivering them, but also for our population as well. So there's a bit more detail in there on some of those. We also were able to, with our public health team at West Suffolk Foundation Trust, we were able to collect and analyse quite a significant amount of data on the activity, especially on the community side, the out of hospital world, looking at the discharge data and highlighting a number of pathways, especially around understanding how pathways 1, 2 and 3, which is the different levels of complexity about patients being discharged from hospitals, how those pathways played out, and actually now in the later stages of the work, understanding what changes we could make in the long term to improve how some of those work going forward. We also did a huge amount in terms of sharing resources across partners. So where previously you have groups of staff who are associated with one organisation, those boundaries in between them, the organisations, were very much flexed during this period. An example being our allied health professionals in Suffolk. Their teams went out, who couldn't do their normal business as usual work, went out to directly support our integrated neighbourhood teams, additional rehab support for patients discharged, and generally becoming part of the broader team, not just in their normal pathways. The furloughed staff, which we had a significant number from some of our system partners, also then have helped enormously with our integrated neighbourhood teams, working directly with the teams and understanding where they could add value. And I think from a personal point of view, we've had some fantastic feedback from them in terms of how it helped them deal with the period of being furloughed themselves. And there's an enormous amount of learning that we've captured from that, and hopefully will continue to. It was our pre-COVID, it was one of our plans to explore, and I think we were able to do it at pace and have proven the model. So it's understanding what that might look like working with those partners going forward. And we've also done some work with West Suffolk FT around their volunteering scheme. The demographic of some of their volunteers in the hospital meant that they were shielded. And so some of the tasks that had previously been done by those volunteers teams needed to be undertaken by other groups. And through doing that, I think we've opened up a new tranche of volunteers who are able to support some of our services. We've also used quite a few of our own staff to do gardening and to do support work, medicines delivery, etc., to be able to help the system more broadly. And I think the feedback from those individuals who've undertaken that work has also been enormously positive. So we've got a couple of examples as well about flexing resources. I think one of the most notable is the work that we did with our local pharmaceutical committee. And there's a bit of feedback in one of the boxes from Tanya Farrow, who's their chief officer of the LPC in Suffolk, where we're able to share some of our staff in terms of the CCG pharmacists, helping directly the community pharmacists, but also assisting with delivering medication and working through some of the conundrums that posed to the wider system. I'm not going to go through it, but there's a section there, section 5 on end of life, where we were able to, with our hospice leading the way, we were able to do a significant amount of work in terms of ensuring that we could operate differently in terms of supporting individuals and their families in end of life. And there's a huge amount of legacy, I think, from that piece of work in terms of how we will work as a team in terms of integration with community services and the hospice going forward. So the only other piece that I wanted to mention was our system executive group, which is the chief exec group of the Alliance, agreed to return to meeting monthly. They'd previously been meeting bi-monthly during COVID, only for an hour, and a very purposed meeting about how the crisis was being dealt with, how resources were being deployed, and using the boards within their own organisations to help to facilitate that. And we've agreed going forward that we continue to meet for an hour, especially going into on a monthly basis, possibly for slightly more than an hour, but going into winter to continue that chief exec leadership and oversight. And then finally, we have now appointed to an independent chair for that group. This was a process that was led by our lay members and elected members in terms of determining the role and the job description and the recruitment process. And I'm happy to say that we appointed Sarah Howard to the role at the end, or 2 weeks ago now, and she's hoping to start at the beginning of September. And we'll try and get her along to a future board meeting to say hello to everybody as well. And then the final point is around our delivery plan. I think we've had an enormous amount of learning over the last 3 or 4 months, and putting that now into practice in terms of what does this mean for our models going forward, and how do we make the most of the learning and the most of the opportunity that it poses in terms of keeping us safe and developing services in the way that we'd originally agreed, to be fair, but it's just taken us on the journey slightly faster. So very happy to take any questions. The governance model is included just because quite a few new pieces of governance popped up as part of dealing with the pandemic, and so at the same time as this is a you've got some new groups within there. It probably is still going to be slightly a moving feast as various other needs arise and forums are required to oversee that.
Thank you very much.
That's it. I'll have to take any questions.
Any question? Oh, Ed, you are first.
Thank you. It's a great paper, Kate. It's really coherent, and it's a great reflection of all the work that's happened across the system. The one thing I didn't read, and maybe I missed it reading it through, was around the work with NSFT and the Mental Health Trust in terms of integration. Whether you could say just a bit about the work that's been happening there.
Absolutely. And apologies, because it's not directly in there, to be fair. There is so much to go in. I'll include it in a future paper. So with NSFT, it's the same theme throughout, really, in terms of, because of the need of the situation, we were able to fast track several pieces of work we've been discussing. So, for example, community services, the community model for mental health in West, working with Suffolk Mind, the NSFT team, which many of you have been part of, worked through discharging or changing the way they were delivering care into the population from a community setting, and adding some additional support mechanisms through Suffolk Mind and through the voluntary sector to make sure that during this time there were no shut doors and there were resources available to individuals when needed. I think that's got really positive feedback, and I think just having that open channel of communication between NSFT and primary care and the patients, I think helped. And I think Richard might add more, but there was also significant progress with the launch of the crisis line. And I think, as with all other sectors, people sort of putting delivery and immediate operational response above anything else really in terms of making sure services were in place.
Thank you. Linda.
Thank you, Christopher, and thank you, Kate. That was a really interesting paper, and I think summarised a lot of excellent work over the COVID period. My question is really around the establishment of the localities and how things might be slightly different in different localities, or whether I just don't get the sense of connection between the Alliance and the localities at this point. And I know that some localities perhaps haven't been meeting in the way that they'd originally been set up over the COVID time. So I'm just not sure how the localities are moving forward at the same time as the Alliance.
So the localities have very much been at the heart of the COVID response. I think during COVID, we didn't have the larger locality conversations, but in terms of the teams working together at a locality footprint, I think that was very much at the heart of the response. So I think our challenge now, we were talking about it yesterday actually, is where you've got the integrated neighbourhood team identity growing and work in terms of response being very centrally focused there. And I think that has developed during the COVID response. I think how that feeds into that wider locality conversation is the bit that now needs additional attention. And I think it feeds into a broader conversation about how we resource some of this at a locality level, because our leadership in the localities has been very much an add-on to somebody else's job. And I think COVID has shown that it does need some dedicated resource, because the response absolutely is happening at that locality level, and that join up is required. And I think you've also asked, the ask is of people who are delivering the service at the same time. So putting some additional capacity around them, I think, will help with what you're saying, because the link is there, and I think we're all pointed in the same direction, and can do fantastic things, as been demonstrated in the last 3 to 4 months. But I think we also need to support those individuals that are being asked to do that delivery.
Thank you. Any other questions? In which case, Kate, thank you very much indeed. We move on now to the community engagement group and the virtual meetings that it's had and the reports thereof. Do we have, who's going to report on that? Linda, is that you? Might be.
I can do. Is Dave Taylor not with us?
I don't see those initials, no.
Oh, he might be having technical problems then. He had intended to come, but he's the chair of the community engagement group.
Mm-hmm.
But thank you. I'll take you through the paper very briefly. We had some technical problems. We did record a couple of our meetings virtually, but unfortunately the recording was lost, so we weren't able to produce minutes in the same way that we have done previously. So what we've decided to do is to present some of the issues that have been under discussion, and just to take you through some of the presentations that we've received as well. What we have decided to do is we were meeting bi-monthly as well, but decided during COVID that we would have shorter meetings and on a monthly basis via Microsoft Teams, which proved challenging, but we got there in the end, and we've had some informative discussions, which is helpful. We have shared information with members via a newsletter, by the stakeholder newsletter going to all of our volunteer members for the community engagement group, and we've received some issues and questions from the community, a lot of whom are shielding or volunteers that are required to stay at home or to isolate themselves, but they were well connected within their communities and were able to bring some issues to our attention, which we've passed on to the relevant colleagues within the CCG and then out towards the delivery teams. The strategy for developing the patient and public involvement continues to develop and to integrate with the wider ICS and Alliance methods of communicating with the public and to receive information and to seek information and involvement from them. I'm delighted to see within the West Alliance strategy that we've got agreement that each of the themes will seek to have their own patient and public involvement, supported by the CCG's engagement team, so that we can look at the involvement in specific themes and in specific areas rather than a generic overview and a generic discussion, so they can be more targeted and more specific. We still have members of our community engagement team at each locality as they are evolving and developing, and we just seek more involvement at that level so that we can share issues between us. We have been involved, and the community engagement team as the community engagement group were very much involved in a stakeholder part of an interview process for the head of patient and public involvement across the ICS, and we're delighted to hear that the appointment has been made. Sophie will be starting with us, I think, in the autumn, and she will lead up that team under the Nursing Directorate. But we also are very much involved with the communication team as well as the quality team to make sure that we are connected across the CCG and issues are shared in both directions. I won't take you through each of the issues. You can see those in the paper, so I'm happy to answer any questions on those. And the only thing that perhaps isn't recorded in there is that members are particularly concerned, as I know colleagues in the CCG are, on the availability of the flu vaccine and how that process will be carried out, with the added number of flu vaccines being promised by the government and the availability of that vaccine, along with the availability of the pneumococcal vaccine. So we are happy to work with and support initiatives at surgery level with the PPGs to see if we can reach the, when the vaccines are available, we can get the public to attend as appropriate. So we're happy to help with that campaign, but we're aware of issues and problems. I'm happy to take any questions.
Thank you very much, Linda. Any questions? Kate?
Can I just add a comment? Just in addition to what Linda's saying, I think we've travelled quite a long way now in terms of the leadership around engagement, and I think I'm quite excited going forward having Sophie in post. I think that should help us significantly in terms of raising the profile, but also one of the key components of that role is linking the various bits of engagement, the various bits of interaction with the patients and public together. And on that note, Liz Steele, who is the chair of governors at the hospital, Linda and I are going to put some time in the diary with her to talk about how we can join those two groups up as well and look at allocating or understanding where the governors sit in terms of our locality footprints as well, and perhaps bolstering some of the voices in those conversations at that level as well.
Yeah.
Thank you. Any other questions? Okay, thank you very much, Linda. We'll let you off the hook.
Thank you.
Item 9, progress on the development of the ideas surrounding a new Sizewell. Amanda.
Thank you very much, Chair. So about a year ago, members will have received an update from Daniel Turner on the exciting Sizewell C development. Since that presentation, Jane Moore, who is one of our senior managers within our estates team, is now project managing alongside her day job and is doing an amazing job. And we'll hear a bit from Jane after my short introduction. But I'd like to just inform the governing body that since the last update given, the health workstream pertaining to Sizewell C has continued to meet, and of recent times has ramped up to meet fortnightly. And that health workstream is basically making sure that any appropriate responses to the project are being fed back accordingly to EDF. And actually this very Friday, the public sector leaders are actually meeting with EDF to discuss the proposals in more detail and to receive the feedback that has been submitted thus far. In terms of the feedback, we are currently in the planning and consultation stage, and all comments pertaining to the new development need to be back to the planning inspector by the end of September. Following that deadline, he then has until May 21 to consider all responses received before announcing the proposed build. A bit of context to actually Sizewell C. It will actually, if built, provide electricity power to 6 million homes and generate electricity for up to 60 years. And if indeed it goes ahead, the 32-hectare site will work alongside Sizewell B with an anticipated completion date of 2031. As I previously said, everybody has opportunity to comment on the proposal, and the deadline at the moment is the end of September 2020. Ongoing lessons are being learnt from Hinkley Point, which will help build Sizewell and hopefully reduce costs thereafter. Sizewell C will take approximately 9 to 12 years to build and will need approximately a workforce of around 8,000 people at the peak of the construction, and the peak is anticipated to be around 2027, 28. Once the Sizewell C is up and running, it's anticipated that 900 skilled staff will eventually work there. In terms of the economy, at least £125 million per year will enter the local economy during construction, and 40 million per year during the 60 years of Sizewell C actually working. Sizewell C is also working with a number of local charities, and to name but a few, Inspire Suffolk and Access Community Trust. The aim of that project and charity is to actually support people to access the many jobs that will become available, including apprenticeships going forward. As I mentioned earlier on, the public sectors are actually meeting alongside EDF this Friday, so I would imagine there'll be lots of lessons learnt and sharing of good feedback will be presented then. Now, as I mentioned at the very beginning, this work has been led by Jane Taylor, who actually joins me on the call this morning. And I'm going to invite Jane to actually add anything by way of context to what I've already shared. So Jane, is there anything you wish to inform the governing body of?
Thank you, Amanda. I think it's mainly about ensuring that we collectively work towards a one system response to the planning inspector. This is more about what the impact will be on health across the system during the period of construction. It's going to be the ambulance service, the ability to get community teams across where traffic will be implicated during the key construction phase. We're going to have a lot of traffic on the A14. The ability for workers to be able to live up to 90 minutes from the development could mean that they will be located within the West Suffolk area and indeed North East Essex. Together with Sizewell C, there is also another development taking place at Bradwell B, and the current national guidance on both these schemes is that they are likely to both potentially go ahead in order to support the power generation for the UK following EU exit. So it is a really exciting opportunity, but there will be a lot of strain on the system, certainly from the regards to things like sexual health issues, mental health issues, drug and alcohol, the county lines scenarios that were already seen previously. So it's ensuring that we have a collective view and stance as we go towards that planning inspector's representation at the end of September. As Amanda alluded to, I am part of a fortnightly health work stream. We meet virtually like this Blue Light colleagues, Public Health, Suffolk County Council, and we go through any scenarios that we've already come up against. We're all meeting individually with EDF colleagues, but then ensure that we share what is being said so that they can't pick us off individually. And we're just keeping very tight-knit communication, and this is what it's about. It's about communication and ensuring that we work together on any representation that we put forward.
Thank you, Jane.
Lisa, you have a question.
Jane, I was just reflecting on what you were saying about the safeguarding issues, and I know that the designate safeguarding team have been involved in it, in the work, but I'm just aware that I don't believe there has been any presentation or update to either of the Suffolk safeguarding boards, either children or adults, and I wonder if it would be helpful to bring an update with the predicted or the anticipated risk around safeguarding to those boards.
Absolutely, that's absolutely fine. That's something that can be done. We can touch base outside, Lisa, and you can let me know when those meetings are due to take place.
Thank you.
Jeff.
Can you hear me? Yeah, thanks. Thanks for that presentation, Jane and Amanda. How are EDF responding to the collective concerns or views of the public sector, including health, please?
I think it's fair to say that they are still stating in all their documentation, so this is the very latest health and wellbeing chapter 28, and throughout the document they are stating not significant impact, low risk, not significant. So I think it's fair to say that all representation that we have provided previously has not been acknowledged. And therefore that means that we need to continue to work collectively, and I am hoping to be able to have a brief section at the ICS board next month, so that we can raise the profile. I also have a national colleague, our strategic estates advisor from NHSI, speaking with colleagues nationally to see if we can get any expertise in to collectively look at health as a whole in support of any representation that we put forward.
Thank you. Ed.
Yes, thanks, Jane. Excellent presentation, and Amanda. I'm just thinking aloud really about COVID. If we're still living with COVID when this work starts, I'm just wondering about the risks of kind of local outbreaks in the Leiston area, etc. If we've got lots of people arriving and working very closely together, it could be quite a risk for us. So I don't know whether we've put any thinking into that yet. I can raise it on Friday at the public sector leaders meeting, but it would strike me as a potential risk.
Yeah, absolutely, Ed. I think currently with the timescales, there is a suggestion that the planning inspector's decision and then Secretary of State's decision may be delayed, depending on where we are as a country with regards to the COVID situation. However, that is something that was raised by colleagues at the last health working group. And it hasn't yet been included in any of the documentation provided by EDF thus far, but it's certainly something that we're pushing for.
Thank you very much. Any further questions? You know what? Thank you very much, Jane and Amanda, for the presentations and the discussion, and we look forward to updates as they arise and as they become necessary. Thank you.
Thank you.
Thank you, Christopher. I will now leave.
Thank you. Thank you very much. Now, I think Lisa's coming at 10:30. Is that right, Amanda?
Indeed, yeah. I think 10:35.
Okay, so we'll need to come back to item 10. in which case we move straight on, I think, to item 11, finance, performance and scrutiny. Mark, are you still sitting in the Jane seat to do us a budget and finance regime review? Thank you very much.
Okay, so I'll just briefly take you through the 2021 budget and financial regime paper. As we've sort of previously discussed, we're under a national emergency sort of financial arrangements which have been in place for April through to July. And these arrangements have included the suspension of the planning and contracting round for 2021, and also the introduction of emergency block payments to providers, and these have been calculated centrally, and CCG has been in effect instructed what to pay on a monthly basis. And also we've been able to claim additional funding to offset the various COVID-19 costs that we've incurred. So we finally received some allocations in late May to cover the April to July period, and when we did receive those allocations, they were a lot lower than we originally anticipated. Some of that's because they've taken account of the block payments, and also some of that's because of the independent sector capacity that's being procured centrally. So those allocations can be seen in Appendix 1. So what we as a CCG have had to do through this period is we submit a monthly expenditure return against these revised allocations, and we are then topped up to a break-even position. Well, that's what we were understood to be the case anyhow. So in month 2, the CCG actually received a top-up, but the top-up only related to COVID-19 costs, which left us with a small deficit of 0.4 million. Now, we've been informed by both the regional and sort of national teams that that's just a technical delay, and that when we finally see the month 3 top-up, the CCG will be topped up to a break-even position. So it's our understanding that during the period April to July, our financial position will be break-even through that period. Now, what we're still very unsure about is how things are going to look going forward for the next 8 months of the year. So there's national work currently underway to build what they're referring to as the NHS financial architecture for the remainder of 2021. This has been delayed until September, and so we're expecting as a minimum that these emergency arrangements will roll over for August. But we've been informed that we should receive a letter very shortly confirming this rollover for August, but also we're aware that nationally there's a deadline for month 6 of the 31st of July, which means it's very, very likely that we'll have a rollover at month 6. So I think what we've seen for the first 4 months of the year, emergency arrangements will be very, very likely to be rolled over for a further 2 months. So when we do see this revised financial architecture, what we've been told so far is it's likely to be a return to an allocation-based system. So we will get an allocation likely for the final 6 months of the year, and we'll have to work to that allocation. And that allocation will include an element of funding to cover COVID-19 costs. It's likely to be a continuation of block payments to providers, although these might be slightly more sophisticated. And although there will be some national sort of elements which may well be either removed from the allocation or we'll be notified of exactly how much we need to pay from our allocation in relation to those, it's going to be very much down to a local system to decide how we deal with the remaining funds. There is a real expectation, particularly around the mental health investment standard, that we still hit these sort of long-term plan objectives. And the mental health investment standard, I think, is one which very much feedback I received yesterday at a regional meeting again was that the mental health investment standard must be achieved for this year, and the indication was that there could be some quite severe penalties if it isn't achieved this year. So there's going to be quite a lot of pressure on organisations in that last 6 months of the year to achieve that mental health investment standard. Although there was an indication that there will be additional funding within the allocations to assist with that, but until we see those allocations, it's going to be very difficult to know. And I mean, there's also been an indication that there may be financial incentives included to actually increase selective activity as we play catch up on the impact of COVID in the earlier year. So like I said, we should receive this letter shortly, and so we should know shortly exactly what's going to happen for months 5 and month 6. Obviously, what's delayed and what we won't know for quite a while, I think now, even though it's saying sort of September, it probably will be late September, and knowing the way guidance has come recently, is these arrangements going forward. So what we're sort of requesting for the governing body today is to kind of note the extension of these emergency arrangements for potentially another 2 months. Obviously, if we receive guidance in time for month 6 to be slightly different, obviously we'll follow the national announcement around that. But also, obviously, what we were hoping to be bringing today to the governing body would be a sign off of of the budgets and financial sort of plan for the rest of the year. And as we're not able to do that, we'd like to ask the governing body to sort of delegate that development of that financial plan for that final period of the year to the Finance and Performance Committee. And obviously, we'll bring that back to governing body for sign off. But we'll run that through the Finance and Performance Committee first. That's all I've got to say around that paper, but happy to take any questions.
Thank you very much. Does anybody have any questions? Jeff.
Thank you, Mark, for that presentation. I understand the challenges that you face waiting allocations for the future. I think my comment really is, given we've got some structural overspendings despite COVID, we're going to only have 6 months to perhaps rectify those, but even more importantly, the allocations for 21-22 might not be as generous as we perhaps think, and therefore we've got some fairly challenging work to do in the next 6 months. So I'd certainly support the Finance Committee getting on doing that work quite soon, because I think we're going to have some difficult decisions to make. Thank you.
I think you're absolutely right, Jeff. Yeah, there's no doubt that although I think the next 6 months will be very, or the final 6 months of the year will be very tough, I think 2021 will be even tougher. And everything that's been indicated to us is that as finance professionals, we need to start looking at 2021, 22 already, and start thinking about our SIPs and QIPs, and making sure that we use the final period of this year to make sure that we're in a real good position to manage 21-22, because I think the reality is that all this additional spending that has gone on during the earlier part of the year will obviously need to be recovered in future years. So I think the NHS will be in for a very tough period.
Thank you. Anybody have any further questions or anything more optimistic to say? No? Okay, well, thank you very much indeed. Let us move on to, would you say you've covered 11 and 12 there, Mark?
No, 12 is
12
slightly separate. So yeah.
Let's move on to item 12 then, the extension of emergency financial arrangements.
Okay, so yeah, this paper is very much further to the previous paper, really. So at previous governing bodies, we've approved a temporary increase in both sort of sign-off limits around the scheme of delegation, and also the establishment of the COVID Resources Approval Committee. So what this paper is looking to do really is to request that as this emergency funding period is likely to continue for a further 2 months, that we extend those arrangements. So I think the appendices show the additional sign-off limits that were previously approved, and probably just need to say a little bit about around the COVID Resource Approval Committee, that I think the proposal is to continue with the committee until we get the new allocations and until we know what the new financial architecture is. I think the committee is going to evolve a bit more now, because we're very much looking at where we've invested through that, and whether we can sort of turn that into sort of business as usual as such, and whether any of those investments need to be extended or not. So really, the sort of question to the governing body is: are they happy for us to kind of carry on with those extension of those temporary financial limits until the end of September? And likewise with the Code Resource Approval Committee. I think there's also another proposal as well around the fact that we feel that the overall scheme of delegation needs a review, and I think this is something that we're proposing that we could do with the audit committee members and support of clinical exec members as well. And we can do some benchmarking against other CCGs to see how we sit as regards our approval limits. I think we're aware that our standard approval limits are quite very low compared to other CCGs in the region, and so I think we'd like to work with the audit committee colleagues and clinical exec colleagues to look at that and bring that back to the governing body in the future as well. So again, so there's any questions around that?
Any questions? Jeff?
Just to say, I'm happy to support those recommendations. As audit committee chair, I think that's helpful. We could review those limits. I think they probably do need looking at. In terms of the CRAC committee, I'm happy for that to continue to the end of September. I think when it's reviewed or the processes are reviewed, I think the membership might need review, and I do believe, I think a lay member or lay members should be part of that, but it could also then fall back to the finance committees. So those are my only comments, but otherwise I support the paper, so thank you.
Thank you very much. Any further questions? Okay, it looks like we have support then. Thank you very much, Mark. Now we are on to the integrated performance report. Let's give it. No, who's going to go first?
Chair, if I may, first Paul Jabbar, hi. First of all, great to be here. Ultimately, this report will be mine, and if I can make a couple of opening comments, if I may, and observations. And then hand over to some of my colleagues who've been breathing and leaving this for some time.
Okay. Welcome, and thank you. Yes.
I think for me, I'm clearly aware this is probably the first time you've seen this report in this particular format, and I'd like to make a couple of observations on that. It clearly goes through a number of sections, which is an overview of the health and well-being of the system, which is the first section, goes through transformation programs, hard sort of quality data and quality on the page, and finance. And you can't help but be struck by the fact that actually it is a report that does really feel as if it's trying to put quality and patient safety at its heart. And I think that's quite striking when you come at it fresh and look at it first time as I did last week. So that's a really positive view that I would take of this report. But I think there are some other things for me moving forward. Clearly it's work in progress, and there are lots of blanks in there at the moment which will work and it will evolve. So I would be happy to take any comments as we move forward with this report. But secondly, I'm really struck by the report that Kate gave around the Alliance, and I think we need to start thinking about how do we capture some of that good work. And I'm thinking particularly around population health management type development, and how we do that and give it prominence, because it is hugely important, I think, as we move forward. And I think the next key message for me around this report is around partnerships. It's very clear that as a challenge system because of COVID, winter activity, or workforce, all those things, partnership is absolutely key to how we move forward. So some thoughts about how we capture that within that report would be really helpful as we move forward. And just finally, a bit of a comment, I think, around some of the hard data, particularly around RTT, cancer, etc. If there was any doubt, I think that COVID had an impact on our performance. It's there on a page, really. And actually, it's actually very difficult to understand performance without understanding the actual detail of the impact. So you might have a very positive performance, but actually if referrals have gone down and there's been more capacity, then you would see, you know, performance improving, like 2-week referrals, for example. It's very clear that the overall sort of picture is that there has been a reduction in referrals. There's been a reduction in capacity for the organisations to manage the activities through, hence why we're seeing lengthening waiting time of RTT and all those things. So again, just to go back to Ed's point very early on, the partnership working around capacity and demand, particularly as we move forward to winter plan, is really quite key, and recovery is really quite key. So that's something that's really going to preoccupy us in a very, very near future, as it is now. So I think I'll pause there and certainly invite any questions. I'm sure my colleagues will try and answer as best we can.
So thank you, Paul. Just over to myself and Lisa and Paul as we go through the headlines for each of the main providers. And Christopher, what we thought would be helpful is if we do a triple act on each one, and then we open to questions and then move on to the next one, because the sections are also interlinked between us. Just for colleagues' benefit, page 85 in the pack, this has got number 3 in the bottom right hand corner. John Reynolds and Keith Ellis have put together like an overarching summary for the pack before diving into the detail of each of the provider organisations. It's fair to say that this is we're still working through it, so this won't be the final version. We'll be bringing that through hopefully to the next governing body. But what it does for each of our main providers is it gives you a RAG rated system for each of the main headings. So quality performance, our demand and capacity, productivity, workforce, etc., etc. So basically in one chart, you get an overarching picture of what our collective views are around the RAG rating for each partner. And then obviously you can turn your attention to the particular part of the pack related to one or more of the providers, and then it goes through each of those headings in more detail. So it's probably unsurprising in terms of some of the overarching RAG rates you'll see there. This pack won't change massively from a month-by-month basis, given the nature of some of the challenges that we'll go through, and we've already talked about over many months, are not going away, and indeed have been exacerbated over the COVID-19 pandemic period and ongoing. We also thought it would be helpful, or I can't take credit, again, John, Sandy and others, is the next slide, which is page 87 in the pack, or number 5 for this item, which has got key issues. It looks complicated when you first look at it, but what it's trying to do is show the matrix way in which we are working across the ICS, the 3 alliances, and across the Suffolk and Essex county boundary. So starting on the left, Kate has already given the update paper on the West Suffolk Alliance, so hopefully these issues resonate in terms of what are the major focus strategic areas at the moment for ourselves in West Suffolk. I would say the first one absolutely will come on to more longer term capacity and integration to developing our PCNs, embedding the integrated neighbourhood team. So that was part of the conversation Linda and Kate were having earlier about the localities, and absolutely addressing health inequalities, which is clearly a theme running through all of our work in the Alliance and through into the ICS. From a pan-Suffolk perspective, again, hopefully these 3 items don't come as a surprise, because again, it's been a feature of the government ongoing work we've got around the mental health transformation programme, the joint working with Suffolk County Council around integration, which Ed and I have had separate conversations in the last 2 weeks with some of the lead directors within the county council, and I think I'm excited with some of the promising moves forward I think we can make both locality alliance and Suffolk wide in that area. And then thirdly, children's services integration. So I'll talk a little bit more about that later in the agenda when we come on to the children's programme, but again, won't be a surprise in terms of the outputs of the SEND inspection that we're working on, the CAMS integration, etc. And then not to forget the ICS wide work, so particularly cancer and stroke, which we're doing on a pan-SNE footprint, but that is implemented through our 3 alliances. So that just gives you a flavour of what we feel as of May are the major overarching strategic pieces of work that we're continuing to work on. And then we go down now into our usual practice of going through each of our major providers. So I think we're starting with West Suffolk FT and with Ms Nobes to kick us off with the quality updates.
Thank you. So, so starting with West Suffolk Hospital, I think that the team have provided quite a comprehensive report on the work that we've been doing, but just to summarise, obviously a key element of oversight is of the West Suffolk's improvement plan against the CQC inspection, and they have just established an improvement board, which Ed and I attended the first one a few weeks ago, which was really helpful. Each SRO presented their improvement plan, and obviously it was open to challenge from ourselves, lay members, and NHS who will be invited going forward. One of the key areas that we are working really closely with them on is the maternity service improvement, and we have agreed with West Suffolk themselves and NHS chief midwife regionally, and Francis Bolger, our Director of Quality for East of England, that we will do a joint QA programme into maternity services. And we've just agreed the terms of reference with the Don. We're going to be looking at providing assurance for those actions against the improvement plan that the trust themselves believe are closed and embedded. So we'll be looking at those specific actions. We're going to be looking at the board assurance, looking at the maternity dashboard and the assurance that the board receives, and the challenge that the board gives around maternity services to that department. And we're also going to be doing a programme of review against the CQC Chloe's, although it's not all about obviously the CQC. It is a helpful framework to test against. So they're going to be multi-agency. The Maternity Voices Partnership will be an integral part of that QA programme, and we will take the report through to the improvement board. Obviously, the other area that we are working with West Suffolk on is the infection prevention and control agenda. They have had, as you will be aware, an outbreak which is now closed, but did have an impact on both St Nicholas Hospice and Newmarket Community Hospital due to transfer of patients. And also, just to let you know, the Helena Jopling, the consultant in public health, has done a really helpful review of the outbreak, and we're going to be taking that through to the next West Suffolk CCG clinical scrutiny meeting so that we can give it due scrutiny. Obviously, oversight on recovery as services start to recover, and in particular cancer treatment, and understanding the levels of harm caused by 2 patients awaiting cancer treatment is a key area. And the other thing that we've asked the Don to review is the safeguarding and learning disability establishment within the organisation. We have an interim director of nursing at West Suffolk at the moment who is doing a great job, and she's going to do some work to understand whether she has the right establishment to support people with learning disabilities in the organisation and safeguarding. And I think just lastly, it's on the report as point 7. I am working with the Director of Nursing and her deputies to review any patient safety risk around the estates risk. I think it's important that the rack plank risk that's been well discussed in West Suffolk isn't just seen as an estates risk, but we understand what the patient safety risk is as well. So working with the Don on that aspect. I'll hand over to Paul or Richard to take us through the other bits.
Thank you very much. Richard, coming back.
Yep, I'm always there. Paul, is there anything you wanted to cover on the performance slides?
No, I think they're pretty self-explanatory, and I think already mentioned, I think the risks and where we are with it. So I'd be happy to try and answer any questions or take anything away. Thank you.
Just briefly then, Christopher, in terms then of the transformation slide, so slide 91 in the pack, or 9 for this item. So overall, and this is a double act with Kate, and Kate's already covered some of this in her earlier paper. The overall programme is rated amber by the team. Probably unsurprising, given that some of the original pieces that we were looking to take forward have been paused due to COVID-19, and Sandy and team have been reviewing which elements we now need to restart and move forward at some pace. Just a couple of headlines from this programme from me. So a new piece of work that is kicking off is Think 111 First, under the first box, urgent emergency care. So this has been a national ask that has come down to the regions and then invariably down to ourselves to look at a model that's been piloted and elsewhere in the country around effectively commissioning additional capacity within 111 to take upwards of 20% of the unheralded arrivals at the ED departments across the country. Clearly, that's not a straightforward prospect. We need to, and we are modelling what the impact of that would be in terms of volumes, in terms of the cost and workforce need at Care UK as our 111 provider, and also, to be frank, whether it's even possible to do that and the campaign that would need to come around that, again, from a national level, particularly as we go into winter. The expectation of the national team is that any model would be in place from the 1st of December. So clearly, we've got a lot of work to do over the next few weeks to start to plan what that could look like. I'm sure you'll all pile in with some questions on that, given the challenges we had before on a national model of GP streaming, but this is non-negotiable in terms of we need to be looking at implementing this as we move into the winter period. So again, we're just working through the detail now with the regional team of what that will involve. In terms of the two that are at risk on this programme, the outpatient transformation programme, probably slightly unfair on at risk, because I think there is a huge amount of work that we've done through the COVID period over moving to virtual consultations at scale. Having said that, I think as Ed alluded to earlier, there's huge amounts of work happening now around recovery and adaptation, of which arguably, as I've said before, our elective and diagnostics work is probably the most challenging in terms of the backlog of demand that is built up. And as Ed also said earlier, we've now we're planning to start from next week a Suffolk and North East Essex wide elective care recovery and adaptation programme. That doesn't mean that the work shouldn't be continuing within each of our 3 acute trusts, but we think there is more value at scale to work on some elements together. So as an example, the clinical prioritisation of how patients will access services we need to be doing across SNE. We don't want to end up into a postcode lottery across our 3 acute trust sites and alliances in terms of setting very different prioritised ways of working. So that's just one example of a number that we'll be working through. And I would suggest, Christopher, that I bring through a paper to our exec once we've worked up in a bit more detail around what that programme will entail. Just turning to the next slide on the strategic programme. So these are the ones that are running pan SNE. Just to pick out a couple. So on stroke, the stroke board has continued, chaired by Dr. Shenton from the East. 2 pieces that are happening, just to bring to the board's attention. You'll recall that we paused the early supported discharge procurement. We are looking to now restart that, and the work has recommenced through Paul's team in terms of the procurement for that. And then secondly, in terms of cancer, which Andy may want to come in later on, there's huge amounts of work happening within the cancer sphere. I would say that as SRO, wouldn't I? We have continued with a fortnightly operational group across the trusts with the CCGs, including Andy and the other clinical leads, which I think has been incredibly helpful as we've started to work through the massive recovery effort that we now need to enter into. We have got the rapid diagnostic centre, the RDC work happening. We're now out to recruitment, which is great for the clinicians within that service, but we've got a massive issue around the fact that we don't have sufficient diagnostic capacity for this. And as a wider point, in terms of our recovery work, diagnostics is proving to be probably arguably the most challenged area in terms of how we actually increase the capacity that we've got across Suffolk and North East Essex to meet the demand we've got on our services. I'll pause at that point because I think all those are arguably you can relate to the West Suffolk FT position, and then I'll come back to children's rather than doing it now because it's a very separate set of issues.
Thank you very much. Ed has a question from perhaps just before the beginning of that part of the presentation. So before we get even further from the topic that Ed wants to raise, Ed, the floor is yours.
Thank you. It was just a comment and a question. So on the RAG rating for the 4-hour standard, it says West Suffolk and indeed Addenbrooke's are red, i.e. targets being missed, but they're obviously not being judged under that standard. And I think under the new standards, certainly West Suffolk is presently performing pretty well. So I just want to highlight that as a correction required.
Yeah. Could we perhaps in future have a grey there, because it does. I spotted that as I was going through the papers as well. It's a bit misleading. So if we could just make it grey, in other words, we've got no visibility on it.
Yeah.
Thank you, Chair. Thank you, Ed. I'd already picked that up, and I'll make sure the changes happen.
Thank you.
The more important point I want to make was, I mean, the impact of COVID is huge, isn't it? When you look at the 52-week waiters, and this data is slightly out of date now, the numbers are huge. So my question is twofold. One, in comparison with Addenbrooke's, which is a much bigger trust, the numbers at West Suffolk are much higher in terms of 52-week waiters. So I'm just, that rings an alarm bell for me, the comparison between the two. And then secondly, there's an action there around clinical prioritisation, I think, of the long waiters. And I just wanted some reassurance about our involvement in that and how that's progressed, because clearly we should be doing harm reviews just to make sure that we're absolutely all over the clinical risk of people waiting a long time. So I just wanted perhaps Lisa your view on this and what more we can do to support the trust to manage the impact of COVID for long waiters.
May I ask a point of clarification before you answer that, Lisa? The Addenbrooke's numbers, are they total Addenbrooke's numbers, or are they West Suffolk patients waiting at Addenbrooke's numbers?
My assumption was they were total Addenbrooke's numbers.
They're total for the whole of Addenbrooke's hinterland? No, I thought...
I'd be surprised. I can double check, but they usually, for all of our providers, the activity of our CCG at that trust. But if you give me a minute, I'll just remind myself.
Okay, thank you, Lisa. Sorry.
So I'm not able to answer the question about comparative with Addenbrooke's data, but around the harm review process, it's absolutely right that we need to have a really robust process, and obviously the trusts do have a harm review process, but it is a key priority for us as my staff return back into the quality team that we will be overseeing. The piece of work about system prioritisation, Mark Shenton and I have been asked to provide a response on how we will understand as a system the harm review across the two providers, our two acute providers, and also to support the prioritisation from a clinical perspective. And NHSEI are also calling an East of England forum to make sure that we are learning from each other in the East of England around the best ways to do that. So it is a big piece of work that we're probably only really now starting to work on, but I can certainly bring back what that process will look like next time.
Thank you. Kate, do you want to contribute?
Yeah, so we are doing a piece of work which we've trailed on several of our catch-up conversations, and I think we're about ready to go, I think, around putting together a team to wrap around. We were talking about it being the entire waiting list, but the starting point, I think, is the 52-week waiters, to proactively call each of them and to, I don't know, I can't say concrete that harm review is intertwined with that, but that would be the beginning of that conversation, and that's linked into our voluntary sector organisations and some of the other wellbeing and allied health professional support mechanisms that we can put in place for some of the individuals that are in that category. So Lisa, perhaps it's tying in with your team about how that harm review dovetails into that, and we've shared that with NHSE and I to feed into that best practice process and conversation as well, because I think that as a system, just building on Paul's point earlier, all partners have agreed to support that because they are the priority group in terms of making sure that we can keep them safe and see them as soon as possible.
Thank you. Right. Richard, do you have any more to say on the integrated performance report?
Oh, we've got lots more to say, Christopher. Okay. Don't worry. Is that the end of any questions from colleagues on West Suffolk FT? I assume, therefore.
Yeah. Can I ask one about the 111 issue?
Yes.
I think the feeling of clinicians on the ground would be that 111 doesn't resolve very much and sends most things on to another provider or clinician.
Correct.
So either that's the case, or there's a lot we're not seeing that are disposed before they get sight of anybody else. And so I think we do need to have an understanding of that point before we know what actually we're going to commission or change to bring in the requirement that you were talking about of a fixed portion of A&E attenders ringing 111 first. Because if they're just going to be told to go there, plus some more besides, then we would be shooting ourselves in the foot. We may not be able to avoid it if it's a national requirement, but at least to understand.
Yeah, so Greg Brown and Nicole Smith are two people working on this who are excellent and all over it. Greg is already broken down what the channel shift at the moment is, as to answer your question. I can't remember the percentage off the top of my head. So he's worked through of those that are coming through to 111, what proportion gets sent on an onwards journey to primary care, out of hours, etc. And what we're trying to do is almost second guess now or plan if they were seeing this 20% unheralded activity going through, so effectively walk-in activity diverted from ED first to 111, what would the likely disposition, which I think is what you're saying, Christopher, be? Yeah. Because actually, yes, there will be a proportion that can be closed through the CAS, through the clinical assessment service within 111, but actually what could be the impact on out of hours and in hours general practice and other parts of our system if we were to shift that activity away from A&E, which might be probably is completely appropriate, to be frank. It shouldn't be going to A&E in the first place, but we will need to look at the financial implications of other parts of the system if we do see that increase.
Okay, I mean, that assumes they're going to A&E already that shouldn't be, and it just isn't the feeling on the ground that there is, but there we are.
I think that's why it's a similar concept to GP streaming, where there's a national model assumed that it will have a equal impact, positive impact in every area of England. The challenge is that we don't have comparatively high numbers of ED attendances by 100,000 population. So we're already starting from a low base. And that's, if you recall, the argument we made at the time when GP streaming came in. So you are right in saying we need to be very careful about adopting a 20% assumption that we could shift that amount of activity away. At the moment, that is the percentage that we're being asked to model for. We have got some more time in the next couple of weeks to actually set out our stall about what we can do before we need to push forward and try and implement something. So again, I think might be another one that we bring through to the clinical executive. I would suggest for consideration.
Thank you, Paul.
Thank you. I was just going to sort of make a similar point to Richard around, but just to say that I gatecrashed a meeting yesterday, and that's a very specific question around disposition, understanding that modelling, so we could be quite clear about what we were signing up to. And again, it really depends on what baseline we're using, whether it's a pre or post-COVID baseline. So again, that's really quite an important question to be asking. So the teams are working on it at the moment.
Thank you. Thank you. Okay, I think on we go, Richard. Thank you.
So NSFT, I'll start with NSFT, and we've reinstated our quality and contract performance meetings with NSFT and have had assurance from them that the clinical staff, care leaders will be able to attend going forward. So from the contract meeting, probably the key area of concern for my team has been around eating disorder service performance, which differs, although we commission a county-wide service, it differs from east to west. They are small numbers of patients, and we do oversee those patients that have waited longer than the service that we commission. So we are really clear on any harm that's caused, but it is a concern. One of the things that Paul and I have spoken about, and we're talking to NSFT about, is moving to a more outcome-based measures as well. As I think we still need to continue, from my perspective, to track access into the services. But I think at the moment what our KPIs miss is, so somebody gets into the service, what's the outcome for that person? Are they, is the issue resolved, or what is the quality of service? So Paul's really keen to do some work around that, and I really welcome that. We talked with NSFT directors in our regular escalation meeting around face-to-face provision from the care coordinators and from other services, and NSFT have reviewed their face-to-face process now as to where we are with COVID, and have agreed to share that. We have had some concerns raised from Suffolk User Forum and other voluntary sector members, and we have seen a higher increase in Mental Health Act assessments and inpatients with really quite high acuity. So we're just working with NSFT to understand if there is any links between lack of face-to-face contact and those presentations into the Mental Health Trust. But I think it's fair to say for adult services, they are seeing increased demand, which for children, young people and families is the reverse. During COVID, we've had a really good system response with Leanne and Gary Joyce from Richard's team at Suffolk County Council and NSFT with SPCN in regular meetings to review the demand and capacity around the children's services across the system, not just mental health, but across the system. There's been some great work that's come from that, which I know we've had presentations from the voluntary sector in the work that they've been done, but we have seen a decline in contacts from children and young people. So just kind of keeping an eye on that and understanding the intelligence from our partners as to why that might be the case. But some great stuff has come out in supporting schools. We're just rolling out an IPC train the trainer approach, as we did with care homes in schools, to support schools to understand how to operationalise some of the guidance that they've had from DFE. And the other thing, just which is really good, is that we currently only have one inpatient into our 2 bungalows at Walker Close, which has allowed NSFT to progress the refurbishment that you'll remember was a key element in their CQC inspection. And yeah, we haven't had an admission since December 2019. I suspect some of that may be related in recent months to COVID, and patients and also the supported living providers wanting to support their residents to remain where they are rather than being admitted. We haven't seen any increase in that would kind of alert us to the fact that people aren't being admitted when they should be admitted. And again, as with the CYP, we had weekly system calls as part of the LD work streams. So, and actually some of the feedback that we are having from our Suffolk County Council colleagues is that with less interaction maybe around people visiting supported living providers and different kind of challenges to the homes, that there has been less challenging behaviour. So there's something for us to learn as part of the LD and Autism Partnership Board going forward. But that's a really good kind of piece of work that sets us on a good journey for the Transforming Care Partnership. Thank you.
Thank you very much. Any questions on that? Okay, on we go.
Paul, have you got anything additional to add on performance?
No, only just to reinforce what Lisa said. I'm meeting with the Deputy Chief Executive Strategic and Ops Director hopefully next week at SFT to start the conversation around outcomes and how we might approach performance slightly differently. So in due course, I'll feedback.
Okay, just moving into the transformation slides. I'll come back to the children's one that I skipped over last time as well. So headlines from the transformation programme. First, on the overarching model and commissioning process that we're going through. The next major deadline is tomorrow in terms of the clinical pathways being developed for each of the 4 priority groups: LD, CAMS, community mental health and crisis. So we've got the mental health board meeting on Monday evening, where that will be a major focus item. And the second element is, as you may recall, we agreed that mental health crisis would be the first of the 4 priority areas that we would look to bring to a conclusion with a commissioning decision. Lizzie Mappelbeck, as Programme Director, will be bringing an update to the board on Monday night, which goes through effectively where our partners and our team have got to on agreeing the model, demanding capacity, the finance, etc., and then looking to go through a short assurance process later in August to be ready to come back to the governing body in September, effectively recommending a decision over our crisis services. We are looking to have a deep dive session, my fault, because I suggested we did need to have one, around CAMS and also for West Suffolk, the community model, also one over in Ipswich and East. So although, as you know, the timescales for those areas and LD was much longer, we were looking to recommission early in the new year. I think it's helpful now just to take stock of where we've got to. And even though August is not a great month for holiday and leave, I think as we're moving further into autumn and winter, it's going to be challenging to keep the pressure on in making sure we're continuing to move through and develop the model. So I thought it would be a helpful check-in, I think, with the partners leading each of those pieces. So I'll be able to report back, Kate and I, through our executive, on what we collectively feel are the positives and the challenges, I think, with those pieces of work. The elements that's slightly worrying me more broadly, as you'll see on the slides with the red areas, and we're not out of line with the rest of England, to get my excuse in now, is around dementia diagnosis, our favourite in terms of the one that we know is very challenging, LD health checks and SMI health checks. Predominantly, this is because obviously a lot of the face-to-face activity has paused over the last 3 months, which has led to significant deterioration, particularly in the dementia diagnosis position. But on LD and SMI health checks, yes, we were pre-COVID, I think, top, particularly in terms of SMI in the region, but everyone is now struggling to come up with mitigations for how we carry those out, where we're still limited, rightly, in terms of face-to-face interaction, particularly given the client groups that these 3 areas are related to. And equally on IAPT, although on the previous performance slide, it was showing that we were in a positive position on our key 2 performance indicators, particularly on recovery, we are now seeing the demand increases starting in mental health services, as Lisa alluded to, particularly with adults, in the same way that the pressure was on acute and continues. I think we're now starting to see an impact into our mental health providers across Suffolk and North East Essex, and the demand that will be coming into our IAP services, I think we're now starting to plan for an assumed significant increase in commissioning activity, and that will come with a cost that we'll need to work through in due course. And then finally, we are expecting a letter from Claire Murdoch as the National Director for Mental Health Services next week, which will be setting out the national expectations around the mental health national programme. I'm not expecting there to be too many surprises. Having been on a call with her, with the regional team, it was effectively, we really need to be carrying on with pretty much every element of the national programme, which, as you can imagine, is challenging given the wider service and operational issues that are being faced by our mental health providers in reacting and responding to COVID. Children's programme, 2 headlines on the eating disorders work that is coming out, again on the previous performance slide, as ongoing challenging. Leanne and Gary are continuing to lead some work with NSFT around how we look at the overarching eating disorder pathway. And I think we need to bring that to a conclusion fairly rapidly. So I will check in with Gary following this meeting. And then secondly, you may recall that we paused our procurement work with the voluntary care sector around neurodevelopmental. So we were looking to go out in an innovative fashion with our parent and carers actually leading a procurement process with the VCSE community around additional support they could provide for pre and post diagnosis support for neurodevelopmental. We are restarting or about to recommence that process, which I think will be really interesting to see what actually third sector can provide alongside statutory sector in this field, which I'm fairly confident they can do a brilliant job of support for those children and families within our neurodevelopmental areas.
Any questions on that? Okay, thank you. And on we go again.
I don't have anything specific really to raise with KUK. Richard's referred to the 111, Think 111 piece of work. There's been an improvement in call answering and category 3 and 4 validations. And Nicole has been really helpful in setting up the clinical assurance group that will review the 111 performance and feed into the regional group. So that group will feed our assurance from a quality perspective in future, but I haven't got anything specific to raise.
Thank you.
Paul?
Nothing, thank you.
Nothing other than just to say that they did hit their 60-second call answer, as Lisa said, but it remains challenging. So I think, particularly again in the context of Think 111 first, if we are going to be increasing the activity significantly, we need to ensure that we've got a clear plan working with Care UK for how they will enable that to happen. And Christopher, I put an update in the chat box in terms of your earlier question related to activity levels and dispositions.
Thank you.
So moving on.
Yes.
Oh, sorry. Did you want to do questions first, Christopher?
Yeah, if there are any, but there are no hands. No. Okay, so we move on. Thank you.
Okay, so so ESEC is next in the pack, and again, it's difficult to really benchmark against previous performance because obviously ESEC's service has changed significantly during COVID and outpatient disruptions. So some of the stats will look as if it's improved. I think we've previously had some concerns around workforce and staff satisfaction and concerns. So the turnover rate is in there, which is 3.5%, which is kind of, if you benchmarked it against other organisations usually sit at 7 to 9% that I'm looking at the moment, but obviously ESEC have a lot lower staff number. They do have some vacancies ongoing, but they have been reduced quite significantly. And they, from, as point 4 said, they have done some patient experience work recently and nearly 25% of patients expressed concern regarding the timeliness of their journeys. I was pleased to see that it wasn't about the quality of their journeys, because we know we have had concerns previously around the quality of some of the care provided during the journey, but obviously timeliness is still an issue, albeit a very small number of surveys that they did. So I think as the service starts to pick up again with outpatients resuming, we will keep a close eye on it. But other than that, nothing further to hand over. Paul, I'll hand over to you.
No, I think the paper says it. I know there's been some additional capacity put in that's led to some improvements. I'm also aware that they've been providing some support across the system. So again, it's a bit of an unusual time to be able to measure them at this stage. As far as I understand, Lisa, and tell me otherwise, but those discussion meetings are still ongoing and still being monitored. So I think the work is ongoing.
Thank you. And on.
And is it me now?
I think we've got
East, haven't we? Yeah,
we've still got East to do, Mrs. Vorton.
Oh, okay, I'm ready.
Unless you want to do East.
No.
So, the key issues around East performance, particularly locally, you will see has been really much improved during COVID. Although we do know that that's because due to decreased demand and increased workforce and vehicle capacity. So how they maintain that going into winter will be really critical, and learning the lessons from their improved performance. From a quality perspective, we continue to oversee the safeguarding allegations fortnightly with the safeguarding lead, and we have 13, well, the East has 13 cases remaining open. You'll remember that when we started looking at this, there were 85 cases. There will always be some cases because of the length of time, if there are police involved, that it takes to resolve these. And obviously, as some closed, others open, but we do have close working with the East to oversee that. We took the independent investigation to clinical scrutiny into the 3 unexplained deaths of ambulance staff, which is obviously in the public domain, and there will be an update in November to review the actions, but more importantly, to understand if there has been any cultural change within the organisation, which is going to be difficult for them to evidence, I think, but we'll bring that back through in November 2020, which will be a year following the deaths of the ambulance staff. There is an update that I just need to make around point 3 in the actions, where it says that the CQC have undertaken an informal visit. It wasn't an informal visit. I understand the inspection has now finished, but it was a visit to review their well-led domain. There were a number of staff interviewed. It was part of their follow-up because of the well-led being scored as inadequate with the CQC. So we'll wait feedback from that. There has been 2 staff outbreaks within the operations centres in Bedford, which we had daily outbreak meetings with the regional team, which Tom Davis, the medical director, has led on, as he's now picked up the DIPSI role and was actually managed incredibly well. 7 days a week, daily outbreak meetings we had with the regional team, and those outbreaks are now closed. And obviously another key area for us is overseeing the issues around the DBS processes and making sure that the remaining 30 of the 300 outstanding DBSs when we started this process are updated. Thank you.
Thank you very much. Any questions on the ambulance part? Okay, now Kate, your turn. Thank you.
I feel I've built it up a bit too much now. we have a slightly new format in terms of the primary care slide, and I think it is a significant improvement. But I think it also the data within it is slightly skewed by what we've been through in the last 3 to 4 months, and I think it paints a really powerful picture of the impact and the journey that we're going to have to go on in terms of recovery. So we've already trailed some of the performance indicators around dementia, LD, and SMI, and you can see that there is a significant challenge there. And I think, again, looping back to Paul's point he made earlier around some of the kind of the role of the alliance and the alliance indicators and the role that system partners are going to play in recovering performance. I think that those three are a very good example of where this isn't something that, from a primary care point of view, can be done in isolation. I think there's some really, I know there's some very positive feedback on how the SMI team has operated during COVID and is now much more embedded than they were at the beginning of the outbreak. And I think that will stand us in good stead in terms of working differently on how we can access those individuals that need that support. And we had Rob Chandler, who is part of Richard's team for mental health, come to have a good discussion, I think, with our clinical directors around dementia. And I think it's tricky because, as Richard says, it's something that we've been working on for such a significant amount of time. But I felt it was quite an open and honest conversation, and we took away from that a few actions supported by Rob, very much led by Rob, with his learning from the work they've done in North East Essex on potentially what we could do as a system to support recovery against that, and also in a broader sense support that group of patients and how they are looked after by the wider system, not just by primary care. So the only other bits that I was going to mention, which we've trailed already, is we've had obviously a significant shift into online consultations within primary care. Activity is very much, and has been for a while, back up to pre-COVID levels. And I think we're now in the process of supporting practices with what business as usual looks like going forward. And we've got cohorts of individuals in their patient groups who are still not necessarily able to access online. And so working through with practices where that's been flagged to support in that situation. We've got understandably a significant overspend in prescribing. Again, we've not had a normal couple of months, and at the moment the narrative from the central teams and regional teams is that will be underwritten, but we're very much working, our meds management team are very much working to continue to support practices in terms of their workload and understanding actually what makes sense going forward to ensure that we maintain quality around our prescribing practices. And from PCN development, we have as part of the response, but is also in line with what the national policy was, aligned care homes with PCNs, and those links have been made. And I think there's been some really positive developments in the relationships with the care home providers. And there is a significant push, not noted on the slide, but just for comment, around the additional roles, which was part of the primary care network development plan, having additional funding for more staff within primary care. We're trying to work through some of the logistics of how that may be possible to pursue some of those roles with the practices. Not always as straightforward as it sounds, but getting some good engagement and appetite in terms of exploring some of those options. And the last point I just wanted to make is we are, and Paul will talk about this when we meet. We are looking at, or there is a draft alliance dashboard for the localities in development, and I think it would be, I'm not going to overpromise for the next board, but I think within the next quarter, definitely it would be nice to have that slide as part of this, because every item almost that we've touched on has an impact at a locality level. So I think that looking at the performance not just by provider but also by location and place, I think is what we've committed to do. So getting that into a good place and sharing it, I think will help in terms of oversight and assurance as well. And that's it from me. Any questions?
Any questions? Oh. No.
Okay. Thank you.
Thank you very much. Right, I think that takes us to the end of the integrated performance pack. Thank you very much, everybody, for your contributions. What I'm proposing to do is to go back to the workforce paper, because Lisa Llewellyn has been patiently with us for over half an hour, and I'm then proposing a 10-minute break. If you don't want that, you might let me know during the via the chat bar during Lisa's paper, but otherwise I think we're all due a little break. But Lisa, I would be most grateful if you would now present your workforce paper.
Thank you, Christopher. That's really helpful. And just to introduce myself, actually, I'm Lisa Llewellyn. I'm actually the Director of Workforce for the Integrated Care System. My background is actually I'm a nurse, health visitor and a midwife, and obviously worked in the NHS for quite some time, actually in a variety of settings, including mental health and primary care as well. So I'm joined today actually by Victoria Robertson, who's actually going to sort of help share to you some of the information that we're going to give to you. So what we're going to do is actually just give you an overview really of a background to the ICS workforce strategy, how we are taking forward the interim and the people plan, the ICS challenges that we've had pre, during and post COVID going forward, and how we're actually moving into adaptation. Developing the ICS board, and of course what we want to do is share with you some of the initiatives that are already underway that probably the board as you would be quite interested in understanding actually how this affects West Suffolk too. So quite quickly I'll actually sort of, I understand you've got the slides, so I'll just refer to certain slide numbers actually as I go through. So the first slide actually is the one that actually gives you the broad background in terms of actually the strategy that we are aspiring to. The interim people plan was published last year, and we are expecting the people plan any day. It depends on the Secretary of State as to which day he is going to publish it. But we've been working actually with the team both regionally and nationally in order to formulate this. And it's going to be no surprises. It actually builds on what the interim people plan said as well. The plan actually sets the vision for our people. We call it the people, actually, in other words, our workforce, and what actions we need to take in order to improve the workforce that we've currently got, and also to attract people actually into our health and care arena as well. The key challenges, and I will actually expand on this, is actually supply. As you can imagine, actually we're always actually saying that we need more of a workforce, so we can explain how we're actually applying that and actually the initiatives that we're undertaking. And more importantly, is the quality of the staff experience is now being the #1 issue when we think about what our workforce. In other words, how are we looking after them, and how do we actually retain them and sustain them in our organisations? And as I said, we'll actually touch on the COVID issues as well. So that actually gives you the background actually for the strategy itself. And then moving on to, I'm moving on to sort of the next one is actually sort of basically these, the people plan have got six key sort of issues. We now think actually that when it is published, this will actually reduce down to 4, but these are the main aspects that we are looking at. And as you can see, we actually want to make health and care the best place to work. And of course, when it comes down to our system, we want our system to be the best place to work. And therefore, we want people to come into our system to be able to develop themselves and then actually obviously sustain actually as well. And those are sort of key aspects actually within the people plan. I won't go through them in detail. And when I come on to sort of the slides 4 and 5, these are the challenges currently in place. They were there pre-COVID. And once again, actually, you can see what the challenges are to us as a system. We've actually looked at our trends and our trajectories, and this is actually the work that we need, that is actually in front of us. This has changed slightly as a result of COVID, so we're in the process of reviewing this to see actually what the impact of COVID has actually on those predictions as well. So quite a huge aspect thing to do. And on slide 5, what you will see is that in our current system in SNE, these are the clinical professionals actually that we have got a challenge, and we are under-resourced currently to meet the future demand, and these are areas that we are focusing on specifically, as well as the broader workforce as well. On slide 6 to 10, you will see actually what we've had to do in terms of COVID. In terms of workforce, this is a key aspect, and this was a key sort of work cell actually that was set up by our system, and we had to act quite quickly in order to look at the health, well-being and safety of our workforce. As everybody knows, this has significantly impacted on our workforce in terms of managing face-to-face actually frontline, as well as actually all the command and the control and the immediacy of all the work that we've undertaken during COVID. So the health, well-being and safety of our workforce is paramount. I can't say enough actually in terms of actually how we need to thank our workforce in what they've done, and that is about actually everybody around this board too. There's been a lot of work. People are quite tired at the moment, and this is actually something that we are looking forward and saying, how can we look after our staff as well? The equality, diversity and inclusion agenda, everybody will have heard actually how that has been impacted upon as a result of COVID, and there's much work going on currently, both within the system, within organisations, and obviously nationally and regionally to address this issue as well. We've seen new ways of working. Virtual consultations has come about, and everybody has welcomed that. And it's now about actually how we explore that and sustain that going forward. When it comes to working differently, we saw a number of people wanting to come and help and work in health and care, and as a result of that we actually upskilled and reskilled many people across the system. That was actually between organisations as well as people new to health and care too. An example I used yesterday was I saw some practice nurses who had critical care skills, and we actually managed to deploy them quite successfully into one of our sort of acute providers to upskill them, reskill them, and they actually worked in critical care during COVID. They've now returned back to practice, but what we're making sure is actually that we're actually keeping those skills under review, and they have opportunities to maintain those so that if we need them going forward, we can actually call upon them again. But the deployment of staff between all organisations were very successful, and that was a result of our mutual aid agreement, which we'd had put in place and was taken up actually by the majority of our providers, including primary care as well. And as I said, we could actually see where the gaps were, and we responded quite quickly to identify and understand what those gaps were and how we could recruit people very quickly. And it's amazing what you can do actually when you're up against it. Actually, the art of the possible was there. So as I said, I won't go into detail, but actually over the next few slides you can see the areas that we focused on during COVID and had to do a lot of work to do. And this is ongoing, it's not going to go away. So these are the examples of what we did. And on to slide sort of 9, this is actually about the recovery from COVID and the areas of work that we now are undertaking in order to make sure things are sort of underway. And in our rapid response to recruitment, you'll see under that third bullet how many people actually we managed to recruit in a very short space of time into our system. And the last bullet actually will explain to you the West Suffolk Hospital specifically appointed 2 new and 2 medical students on bank contracts, and we've seen that increase even more as the time has gone by. We also referred allied health professions and deployed the 19 third-year student nurses into West Suffolk Hospital. West Suffolk Hospital actually was the first one across the region to employ the third-year student nurses very successfully, and we've nurtured and looked after them quite well as well. So that's sort of into sort of recovery. On to slide 10, you'll see recovery, health and well-being. This is something that we are doing continually. During COVID, actually, we had to set up a lot of psychological help and support for our workforce, the workforce across the system, to the volunteer workforce, and the care home workforce too. So we made available to everybody a lot of support services that they could access quite quickly and quite easily. We worked with Mind in order to develop the services at different levels as well. And I have to actually commend actually our mental health providers, where they stood up actually on day one and said, you know, if there is a need for psychological support to the workforce, we are prepared to offer that too. And everybody actually sort of, you know, adapted really well to this, and it's an ongoing issue that we have to address. Going forward, it's moving into recovery and transformation. And as you can see, these are the challenges that we have ahead of us. We need to support our people going forward. We need to learn the lessons. More and more now, actually, we are standing up to the services that had to be paused during COVID, and that includes all our education. So how are we working with the region to not recommission, but re-stand up to the education of our doctors, our nurses and our allied health professionals? More challenging now because we haven't got the placement opportunities that we had previously, because we obviously have to look at infection control, social distancing, and how people actually can access appropriate placements to make them good professionals. The ICS workforce strategy is now being revisited and refreshed, and we will be coming to you as West Suffolk CCG to be engaged in that process to see what that means to you going forward. And we're also actually developing the people plan and developing actually sort of ICS people boards. We're in the throes of developing that as we speak, and the regional people board has just been initiated. So that's really good news, given that the people plan is imminently due as well. Slides 12 and 13 just gives you an example really of the areas of work and the delivery of workforce, all the workforce issues that we have to deliver, and how that can be deployed at a national level, regional, system-led and organisational. And dare I say, when I look at that organisational delivery, we are very fortunate in SNE that we have 3 alliances, and we'd be working with the 3 alliances together with the organisational delivery to meet the needs of our population as well. So much work already underway, and we will be hearing system by default even more as we go forward, because the region is working with us to share actually what their initiatives are as well. And as I said, sort of slide 13 and 14 is just giving you an example of how we are going to develop an ICS people board, and how the previous local workforce advisory board will transform into that board and what we need to do. But I have to say, we have engaged with system partners. We have a huge commitment from local authority as well as healthcare providers and other organisations to make this work. So we've got the good foundation to build on in order to develop a really successful ICS people board that will deliver what we need. Moving forward, on slide 15, you'll see the current arrangements that we have in place, and what we are doing actually through the strategy and the development of the people board is seeing how that will evolve into a more efficient and a more effective workforce delivery group. And I will say that where you've got the West of all the local workforce advisory groups at the bottom there, we will actually sort of be working with the alliances in order to develop that much more effectively, but also working alongside that in terms of primary care. We currently have primary care workforce just to the side, but we want to integrate that in because it's really important as we take primary care networks going forward too. So much work is underway. The supply priority, or as I mentioned earlier, supply is a key aspect. We have got to nurture more people to come and work actually in health and care. It is our #1 sort of priority in terms of what we need to do. And there you can see a number of the initiatives already underway where we are recruiting from school leavers all the way through in order to try and attract people to come and work in health and care. We've never had it so good in terms of press. We've had lots of people actually approach us wanting to actually come and work, and this is where it's quite important to provide them actually with the right information at the right time and the right linkage in order that we can progress their careers too. Really exciting. And this is working with higher education institutions, further education colleges, schools, and our current organisations too. So in terms of supply, on one of those slides, we talked about the Health and Care Academy. And what I'd like to do now is actually just hand over to Victoria, because this is quite a successful initiative actually in our system currently. And she will describe to you as to the huge amount of work that's currently underway, including in West Suffolk, to actually develop our Health and Care Academies. Victoria, over to you.
Hello, I'm Victoria Robertson, Deputy Director of People and Culture working across the ICS. I'm just going to give an overview of the Health and Care Academy programme and all the different work streams within it. So we have a junior and senior academy. This is formulated on 3 hubs that mirror the alliances with an offshoot into the tendering area, looking at the specific health inequalities in that area. The West Suffolk hub is very well established. We're looking to expand and move it into the wider alliance partnership, but it is well established in its current format. These hubs and the junior and senior academy look to engage the young people, 16 to 18-year-olds, and bring them into health and care, providing an insight into the careers that are possible. Not only clinical careers, but also the wide range of careers that we can offer throughout the health and care sector. It also provides them with very key skills like interview skills, mindfulness, starts to talk to them about health and well-being. So it's a package that gives them a really good overview and really engages with those young people. We also have a work experience portal. This is up and running, although slightly paused through COVID. And the premise of the work experience portal is it matches any alliance partners with individuals, the population, any age that may wish to come and experience what it's like working within health and care. Primarily, this is young people, but it means it's a very accessible way of attracting people into the area. We're looking at, in the short term, turning this into a virtual process, but over the long term, we'll go back to face-to-face work experience. We also have an NHS cadet scheme within our area, and we're looking to bring that into the Health and Care Academy. Again, a great way to engage with the young people and run through the St John's Ambulance Service. We're developing a marketing and careers portal. So this is essentially a website which will make engaging with the young people across our local area really easy. It sets out all their career paths they can take. It sets out the training opportunities and makes the individuals very aware of what we can offer. This leads into making sure our employment and training is accessible and clear. And we also want to build on an alumni. So making sure that we can track these young people into careers in health and care, making sure we stay engaged with them and help them and support them into the workplace. That slides to 16 to 19. We'll also touch on apprenticeships. So we have a very established apprenticeship collaborative. It's been formed recently, but it's driving ahead and it's currently developing the strategy. So we need to use our apprenticeships to bring new roles into the area, bring new supply of workforce into the area, but also for the education development of our current workforce. We're looking to build a strategy that helps us develop what we need from our HEIs, but also look at new apprenticeships that meet the needs of the workforce and meet the needs of the employers that we have in our local area. This is underway at the moment, and we're also hoping to develop out of hospital models that can support the current supply of workforce within the hospital sector. Okay, I'll hand back to Lisa.
Thank you, Victoria. So our next slide on 21 is about retention priority areas. I can't reinforce enough that retention of our workforce is key. It's okay actually to recruit people actually, but how do we keep them? We know currently actually that we do lose people actually through our sort of workforce, and it's about understanding why that is the case. And you will see actually in our people plan actually and the national people plan how we actually sort of need to look after them. We're talking about core offers in terms of actually when you come and work with us, what can you expect? In other words, how do we actually treat our workforce appropriately? And it comes back to sort of what we're saying is actually developing good leadership and culture. As an ICS, all actually partners have signed up to the Leadership Compact. And I'm hoping actually that everybody is actually taking that back down into their organisation. But it shouldn't sit just at the senior level. It needs to be adopted and actually implemented all the way down into our system. And where you see good leadership, you see people actually valued, and actually those people actually are the ones that are likely to stay as well. And a compassionate culture is key. People actually want to feel valued actually going forward, and this is actually more importantly now actually as we go take these initiatives forward. The learning and development, I touched on this in terms of our education programs. These are now challenged because obviously the programs are now becoming virtual, but we've had to do this quite quickly because we can't waste our time. We haven't got time to wait. So working actually with Region and the HEIs to say, how do we set these programs back up quite quickly? We have challenges in some arenas, for instance, actually the care sector. The care sector currently are challenged in terms of releasing their staff in order to do placements elsewhere, but we have to work around that and work with them to enable them to do that. The health and well-being of our workforce, I say it again and again and again. I think we all need to thank our workforce for what they've done during COVID. There's an anxiety that if we did actually have a challenge again with another peak, that our staff are very tired and would they step up in the same way? And we need to recognise that and encourage them to take the rest and recuperation that they need. We're now actually near to August and we should be encouraging them to take the annual leave that probably many people have put on hold as a result of COVID. It's important to stress to our staff that they need to take rest and actually switch off in order that we actually sort of encourage them. Psychological support is actually something that every single organisation in our system has identified that we need to invest in going forward. So we are exploring that as a system to say actually how can we deliver that to our workforce by working together rather than actually working in silos. And then coming on to transformation, we've seen new roles to develop as a result of COVID. We've got new opportunities to think differently. Digital is just one example, but we've also seen a reduction actually in agency need, and therefore the question is actually can we encourage those people that we've deployed into our area to be taken onto our bank? And this has happened. We've seen evidence of this happen. People have deployed into an area to work actually as a frontline nurse. We upskilled them and actually sort of they were able to do that. They are now returning back to their normal work, but they've actually said that their intent is that they want to be put on the bank and actually do a few shifts now and again. This is absolutely important because if we do experience another peak, we actually need to make sure that this skill set is there. And we are currently working actually with our providers to understand what upskilling happened, how did we reskill them, and what do we need to maintain going forward. So that's the aspect of that one as well. I mentioned the Leadership Compact. These are the areas who I'm sure nobody will disagree with that we need to adopt and actually apply and behave in this appropriate way going forward. This actually makes us actually a compassionate, caring organisation that people will want to come and work with. So quite briefly then, in conclusion, as you can see, what we've given you is a very whistle-stop tour of what we are doing in terms of our workforce, what we need to do effectively and efficiently, and Our experience currently is that things are standing back up quite quickly, all at the same time. And you will also have heard how the government is reacting to the economic downturn and how people are unfortunately losing their jobs. We're obviously trying to exploit that and work with some employers to see how we can recruit them into. An example of that is the airline industry. But also from next week, you will hear more about the apprenticeship opportunities with the Kickstart, where the government has put additional money, where employers will receive some funding to take on additional people as well. So it's about the health and well-being of our sort of population as well as our workforce. And we know that by encouraging people to come into employment, that is a key determinant of health as well. So it's important to do that. So, Christopher, that's a real whistle-stop tour of what we're currently doing. And what I will assure you is that you are having these conversations with organisations and the West Suffolk Alliance to take the things forward as well. But happy to take any questions.
Thank you very much. Any questions? Kate.
Can I just add a small bit? Because absolutely, as Lisa said, she's been a brilliant support and we've worked very closely during the last few months and will continue to do so. I think our collective challenge, and we've talked about it a lot, is how do you, we've got our team, our ICS team, our integrated care system team under Lisa, and how do we bridge the gap between a practice with the workforce conundrum and feeling they've got their own workforce team, that actually they can work that through. So making the translation from these are the national policy must-dos to actually what's the need for that individual practice to ensure that their services are robust and develop, etc., etc. And that goes through, I think, each of the system providers within the alliance. So I think that's our challenge, and we're hoping our local board, when that's up and running, will be a key enabler for that. And I think that it's helped. On a very personal note, I think it's helped to raise the profile, the ability, and what we've achieved in terms of moving staff quickly, skilling staff up, etc., etc., has opened quite a few people's eyes, I think, locally, especially within the acute sector, to the fact that actually having a system conversation about how we share resources is absolutely important for their organisation in terms of making it a priority going forward. The only other point I wanted to make is we've got another challenge pending around our flu vaccination programme, which is going to take a significant amount of workforce to roll out and make sure we achieve to our full level of ambition. So I think that's going to just to put a line in the sand, that's absolutely going to be one of our priorities in the next few weeks.
Thank you, Kate, and you're absolutely right. And when I say providers, I include the primary care networks as part of that provider network as well. And we're currently working with quite a few of primary care networks that are developing their workforce plans, because it's not about just being reacting as to what they need now. We need to understand what their needs are going forward and how we are recruiting directly into primary care. We've got opportunities where we've got nursing associates now, so we're working with practices to say, how can we develop some of your staff to become some of our practice nurses of the future? We've got Sarah Isaacs as come in working with practices, and yes, we've linked with Suffolk Primary Care and many other PCNs working with your team as well. There is a lot to do, and yes, but you are part of that, and we will definitely go forward with that. And yes, I know flu is a big issue, and we're already exploring what we can do altruistically to do that as well.
Thank you. Ed.
Thanks again for the presentation, both. So this is more of a comment and a thought than anything else, but you rightly talked about staff exhaustion and that being a big issue. There's a lot of talk in the papers today about a second peak growing in Europe, and potentially a few concerns that the Prime Minister has raised about the UK, and people are cancelling holidays because of the quarantine in Spain, etc., and people concerned going abroad. So there's just a bit of a worry I've got that people aren't going to take the break this summer for various reasons, and the second peak starts to appear, let's say for September, October, that we're going to head into that with very tired staff have had a break. So not asking you to play God and solve that for us, but it's just a worry I've got.
I think you're right, and if I'm honest with you, we've got to, I talked about leadership as well. I think we've got to be ambassadors and actually behave in that way as well, and that's why I'm saying everybody. So we should be taking the annual leave that we should be having, and we should be encouraging all our staff to take that leave, despite the fact that they're not going abroad. I think they need to take that time off as well, and we should be encouraging that, because there is a reason for having annual leave, and it's not just about going abroad. It is about for people actually to take that time out. We're also looking at initiatives about how they can, each week actually Carolina, sort of sends issues around the CCG, I know, but all our providers are looking at that as well in terms of how they can support their staff. And this is an opportunity whereby if we can recruit more people to be on bank, then people are more assured that we've got that backfill available. But your point is well made, and I reinforce this at every opportunity, because we just need to make sure we are valuing and caring for our staff as well, and it is our responsibility.
Thank you very much. Any further questions or points? Once again, Lisa and Victoria, thank you very much for being with us, and for a most interesting and thorough presentation. Much appreciated.
Thank you.
Bye-bye.
Bye.
There have been no dissenters to taking a break, so I propose we take exactly 10 minutes, and therefore at 11:47, we will reconvene. Please turn your cameras off while you're going to do whatever's necessary, because don't forget we're live streaming. 11:37, sorry, 47, 11:47, see you again.
Hi, Christopher. Can I also just please turn your microphones off as well, please?
Yeah,
thank you.
Thank you. Thank you.